Ujjwal.
So, respected seniors, teachers, dear friends and colleagues, good evening, everyone. On behalf of Hyderabad Nephrology Forum, I welcome you all for this monthly meet. I hope all of you are doing well. As you know, we are all conducting these virtual meets for almost last 2 years in this pandemic period. And we are hoping to conduct physical meets very soon. For today's monthly meet, we have excellent faculty, chairpersons, moderators, and we have 3 interesting case scenarios to discuss today from different hospitals across Telangana. One is from Nizam Institute of Medical Sciences, another is from Krishna Institute of Medical Sciences, Hyderabad, and one more is from Pratima Institute of Medical Sciences, from Karimnagar. I am sure that it would be a good exercise, and we take home at least few important points to implement in our clinical practice. So with this introduction, hand over to Dr. Swanata Madam to give a welcome message for this monthly meet. Madam.
Thank you, Praveen, and I welcome you all to this nephrology monthly activity. So it's my duty to update you about the nephrology forum. So we had a meeting, executive body meeting last month. So we have discussed about the agenda, how to take it forward. So we have discussed few points. I just wanted to share those things with you so that you are aware of all this activity and you can also participate in the upcoming activities. The first thing what we thought of is expanding the forum to include the district nephrologists from the districts as well. Initial to begin with, we started with Hyderabad because nephrologists were there only in Hyderabad. Now that most of the hospital, the teaching hospitals are coming up in the district hospital, and then recently government has also announced the filling of the vacant posts. So I think in future we are going to have a lot of nephrologists from the districts as well. So to have the inclusivity, so we wanted to expand it, and that's why we wanted to rename it as a Telangana Nephrology Forum. But again, we are working on like whether it's possible to change the name or shall we continue with the same name, and principally try to accommodate everybody. So with that intention, we have already started working on it, and we have tried to, you can see our agenda this month that we have included one case presentation from the Karimnagar and one presentation from the other hospitals as well, not only to the restricted to the teaching hospitals. So that was one agenda. So our people are working on that. We are trying to contact the resources so that whatever is feasible with respect to the registration process, the bank and the IT returns, everything. So we're working on that. Second thing, we have tried to redefine the registration, the membership actually. So we wanted to also include because now that we have postgraduates from several the states, and they are passing here and then going back to their own states. So they wanted to have the membership from the other states as well, so that they can be the member and they can continue learning the process of learning. So, but they don't have the role of what you call the right of voting. So we wanted to have a membership from the other states as well. And of course, we'll have a membership, associate membership to include the other specialties, and then the elite membership to include even the paramedical staff, including the nursing staff and the technicians. So we will be distributing the membership forms to include all these members shortly. And third was updating our website so that it can be live and it can be vibrant, and we can update all our activities. We have formed a committees for all these things, and Dr. Vikram is looking at the website. So we are also trying to revamp our website. And fourth was to expand the activities, academic activities. One, of course, we are doing a monthly activities. Apart from that, we would like to have once in 3 months some international meet. Dr. Manisha and Dr. Shrikant would be working on that. So hopefully next month we'll come up with one such activity. And then we have the Twitter also. Dr. Wali is handling the Twitter. We want to update our the Twitter handle also to vibrant. And Dr. Wali will form his own team and will work on that. Apart from that, we'll also have other academic activities, including the mock examination for the DNB and the DNB students. Dr. Manjusha and Dr. Kiranmay are working on that. So probably next month, April or May, we'll also have that also. So it's still open. So we invite all the input. Slowly, we'll try to incorporate all these things and we'll move forward. So with this brief, briefing on how we are going to, move forward, I would now request Praveen to take over. And then I wish this discussion will go on more active way, and there will be a learning for all of us. Thank you. Please, over to you, Praveen.
So without wasting much time, we'll start with the proceedings of today's program. I welcome the moderators of today's program, Dr. Vali sir and Dr. Srikanth sir, who are very familiar to all of us. And I am privileged to say that I worked with both of them. Dr. Vali sir was doing DM when I was doing MD at Usmania, and he taught me how to put a rigid PD catheter bedside for the first time. And Dr. Srikanth sir, I worked with him in ANU Somajuguda during initial part of my career. Dr. Vali sir is now working in ANU Dilsukh Nagar as a senior consultant, and Dr. Srikanth sir at ANU Somajuguda. They are not only good teachers, but also very kind at heart. I request them to start the proceedings of today's program. Over to moderators.
Srikanth sir, can you take over?
Yeah, good evening, everybody. So today's program, I'm sure would be an interesting program to discuss about the academics. There are 3 talks, as I've already been told. For the first talk is by Dr. Tanvi. She'll be talking on an interesting case series of post-transplant lymphoproliferative disorders. So the chairpersons for this talk would be Dr. Ratan Jha and Dr. Sanjay Maitra. Dr. Tanvi, please start the talk.
Sir, actually, I am not able to share my screen as some Dr. Nath.
This case vintage, I think, Dr. Mukesh sir, please stop the screen. Dr. Nath.
Yes, Dr. Vali. So like at Srikanth, this is one vignette we wanted to have. I request Nath to just put up the case details and the image. So we'll invite, the answers, and then at the end, he will be revealing the, this is one interesting thing we wanted to have for the students, so the student can interact, and, the learning process will be more interesting. Dr. Nath, please.
Yes, ma'am. Good evening, respected faculty. A short case vignette. Mr. PGR, a 55-year-old male, non-obese, diabetic kidney disease, native kidney disease, with a 48-month dialysis vintage prior to transplantation. He received a disease donor renal transplant in March 2021 at NIMS Hospital. He received induction with anti-thymocyte globulin, and he had delayed graft function and was on triple immunosuppression. He had a normal graft function of creatinine 0.8. In May 2021, that is 3 months post-transplantation, he presented with fullness of lower abdomen and urinary frequency, which was increasing over the past 2 weeks. In the next slide, I would like to present an ultrasound pic which shows a perigraft collection. Please leave your diagnosis in the chat box. Thank you.
So that would be an interesting case discussion. I hope that the answer will be relieved as we move on in our talks. So can we go on to the first talk by Dr. Tanvi?
Good evening to all the respected teachers and my colleagues present today. I'll be presenting about few interesting case series of PTLD and patient outcomes at KIMS Hospital. Coming to introduction, PTLD are lymphoid and plasmacytic proliferations that occur as a result of immunosuppression in the setting of solid organ or allogenic hematopoietic stem cell transplantation. Epidemiology, incidence of PTLD is up to 20% in solid organ transplant, and it depends on the transplanted organ as the amount of lymphoid tissue transplanted varies, and the intensity of immunosuppression required to.
Dr. Tanvi, slides are not moving.
Is it okay now, sir?
We are still in the first slide, Tanvi.
Are you not able to put on slideshow? Like,
This is actually slideshow only, sir. One second, sir.
at least move the slides. One way.
No. You click on the slideshow. It will get activated. Yeah. Click it up.
Are they moving, sir?
No, it's not moving.
Okay, you can at least present without the slideshow mode because sometimes the slides don't move in the slideshow mode.
Okay, sir.
If your slides are moving, you can continue.
Yes, please continue.
Moving, sir?
Yeah, now
Yes.
they are moving.
Moving
Yeah.
now, it's moving now.
So epidemiology, the incidence is up to 20% in solid organ transplants, and the difference is due to the amount of lymphoid tissue transplanted and the intensity of immunosuppression required to prevent graft rejection of that organ. The recipients of intestinal and multi-organ transplants have the highest risk, followed by recipients of heart and lung, liver, and then kidney. Hematopoietic stem cell transplant recipients have lowest risk. The timing of PTLD after solid organ transplants follows bimodal distribution with highest rate in the first year and second peak occurs 10 years post-transplant. Early onset PTLD tends to be generally EBV driven and involves the allograft, whereas late onset PTLD is often EBV negative and involves extranodal organs. So our experience at KIMS, so far from 2004 to March 24, 2022, a total of 1,178 patients underwent renal transplantation, of which 933 were living donor and 245 were deceased donor transplants. Among them, 6 patients were diagnosed to have PTLD. So the incidence comes around 0.5%, which is actually not the true incidence because many patients from outside other states come here for transplantation and they are at follow-up with the local nephrologist. So this is not a true incidence. So coming to patient 1, patient 1 is a 30-year-old female who underwent renal transplant with father as donor in 2011. HLA mismatch being 3/6. Viral markers were negative pre-transplant, CMV seropositive. Induction was not given. Immunosuppression, she was on triple immunosuppressants, steroid, tacrolimus, and MMF. No rejection episodes were there during follow-up. In June 2021, she had pancytopenia and bone marrow histopathology was suggestive of hypoplastic anemia, after which tacrolimus was stopped and cyclosporin was started at 200 milligram per day. Then in June 2021, that is 10 years post-transplant, she had severe abdominal pain. An ultrasound abdomen was suggestive of multiple hypoechoic lesions in left lobe of liver. So liver biopsy was done and histopathological examination was suggestive of PTLD. EBV DNA quantitative PCR was negative and immunohistochemistry panel showed CD20 diffusely positive in atypical lymphoid cells with scattered T cells in the background, suggestive of monomorphic PTLD, diffuse large B cell lymphoma type. She received the treatment she received was firstly cyclosporin was decreased to 50 mg BD. Then she received 4 cycles of rituximab 500 mg weekly for 4 weeks. Then response assessment was done using PET CT, repeat PET CT. Then she was switched to R-CHOP regimen. After the first cycle of R-CHOP regimen, the patient had neutropenic sepsis and she succumbed to that. And the overall survival in this patient was 3 months after diagnosis. So second patient is a 16-year-old male who underwent renal transplant with father as donor in 2011. HLA mismatch being 3/6, viral markers negative pre-transplant and CMV seropositive status. No induction was given and he was on triple immunosuppressant. In April 2012, that is within 1 year of transplant, he developed weakness of both lower limbs with retention of urine. MRI spine was done and which showed D8, D9 epidural granulation tissue causing cord compression. He underwent D8, D9 laminectomy and granulation tissue was sent for HP evaluation. And HND section showed presence of atypical lymphocytes. In immunohistochemistry was CD20 was positive in most of the lymphocytes and also there was presence of T cells which was suggestive of polymorphic PTLD. The treatment he received was firstly MMF was stopped and tacrolimus dose was lowered. And the patient responded very well to the reduction of immunosuppression and had a good graft function till 9 years. But presently he is undergoing maintenance hemodialysis from 2020. So his overall survival was 10 years. Coming to patient 3. Patient 3 is a 28-year-old female who underwent renal transplant with mother as donor in 2011. HLA mismatch being 3/6, viral markers negative, CMV seropositive status, did not receive induction and was on triple immunosuppression. In June 2018, that is 7 years after transplant, she presented with severe backache radiating to left lower limb. MRI spine was suggestive of multilobulated lytic lesion involving sacrum with focal nodular lesions involving L2 and L5. And CT guided biopsy was done, which was suggestive of polymorphic PTLD with a mixture of small and medium sized lymphoid cells and few plasma cells. EBV DNA PCR was done, which was again negative. Treatment, MMF was stopped and tacrolimus lowered. She was put on CHOP regimen and additionally cytarabine was given. Radiation therapy was done for pelvic mass, but she passed away within 1 year. So her survival was 10 months after diagnosis. So this is patient 4 is a 26-year-old male who underwent renal transplant in 2005 with father as donor. HLA mismatch being 3/6, viral markers negative pre-transplant and CMV seropositive status. Did not receive induction and immunosuppression was steroid, cyclosporin and MMF. In March 2006, that is within 1 year of transplants, he developed cytopenias. Bone marrow biopsy was done and it revealed polymorphic PTLD. EBV DNA, I could not find his records of that. But he passed away within few months due to neutropenic sepsis. And this patient 5 is a 35-year-old male who underwent renal transplant with mother as donor in 2012. HLA mismatch being 3/6, viral markers negative and CMV seropositive status. Induction was not given and he was on triple immunosuppressants. In October 2021, that is 9 years post-transplant, he was evaluated with severe headache and bilateral lower limb weakness. MRI was done, which was suggestive of T1 hypointensity, T2 and flare ISO2 hypointensities involving bilateral frontal lobes and with perilesional edema and also cerebellum. Then stereotactic biopsy was done under navigation guidance and HND stains showed a cellular lesion composing diffuse infiltrate of tumor cells, angiocentric pattern, suggestive of non-Hodgkin's lymphoma. Immunohistochemistry was advised, but the patient got discharged against medical advice. But we came to know that he passed away after 1 month. So this was his biopsy from the brain biopsy. Patient 6 is a 27-year-old male who underwent renal transplant with unrelated donor elsewhere in 2017. HLA mismatch not known. Induction, he received 3 doses of ATG. Immunosuppression, he was on steroid, tacrolimus and MMF. In June 2018, within 9 months of transplant, he developed fever with chills. So he was evaluated and the diagnosis was pyrexia of unknown origin. EBV DNA was done, which was positive. Then FDG PET CT was done, suggestive of hypermetabolic ill-defined lesions in transplant kidneys in the upper pole, interpolar region, and also along with that, there were inter-iotocaval and right common iliac lymphadenopathy. CT-guided renal biopsy was done, which showed patchy, dense interstitial lymphoid infiltrate. Immunohistochemistry showed the mixture of CD3 and CD positive lymphocytes with few scattered CD30 positive immunoblasts, suggestive of polymorphic PTLD. MMF was stopped for him and he is currently doing well. His latest creatinine is 1.19 milligram per deciliter. This is his PET CT findings where there was increased uptake in the allograft kidneys. The renal biopsy slide I could not retrieve as it was done in Apollo, but I could only get the report. I could not retrieve the slide. So to summarize all these about all these patients, first one developed monomorphic PTLD after 10 years, the second one after 9 years, third one after 7 years, and all these 3 had poor outcomes with survival lasting less than 1 year. The next 3 patients had PTLD diagnosed within 1 year of their transplant, and 2 of them have had good outcomes and they are doing well. To summarize, the patients with late onset PTLD that is greater than 5 years were EBV negative and had poor survival. The patient with early onset PTLD who were diagnosed within 1 year with EBV positive and had good response following reduction of immunosuppression. So the risk factors for PTLD, for early onset PTLD, EBV infection or reactivation and induction therapy with T cell depleting agents are most important risk factors, and for late onset PTLD, immunosuppressive state and the recipient age are important risk factors. Coming to EBV status, mostly 85 to 90% of the general population are EBV seropositive, and more than 50% of PTLD are EBV related. When there is a donor and recipient mismatch, there is 12-fold increased risk in development of PTLD. The incidence of early onset PTLD is higher in children because more than 50% children are seronegative. Coming to immunosuppression, PTLD is reported to occur at a higher rate in heart, lung, and intestinal and multi-organ transplants because they require higher degree of immunosuppression. And the degree of T cell immunosuppression appears to be more important because it impairs the EBV specific T cell mediated immunity. Coming to ATG and PTLD, there are conflicting data on risk association of ATG with PTLD. In UNOS data analysis, comparison was done between ATG and IL-2 inhibitor induction, who were kept on calcineurin based maintenance therapy. And it was found that ATG was associated with increased risk of PTLD. In Australia and New Zealand dialysis and transplantation analysis data also, the patients were treated for rejection with T cell depleting antibody, and it was associated with higher rates of development of PTLD. And the second Fall et al. Also conducted a study on the same Australia and New Zealand dialysis and transplantation analysis, and he found that ATG per se was not associated with increased risk, but when used in combination with calcineurin inhibitors was associated with increased risk of PTLD. Anti-IL-2 receptor antagonist was compared with no induction, but there was no difference in the incidence of PTLD in both the groups. And CNI-based immunosuppression was associated with significant increase in the risk of non-Hodgkin's lymphoma. Among both of them, tacrolimus was associated with increased risk of PTLD. Antimetabolites, higher dose of azathioprine was associated with increased risk, and MMF doesn't affect the risk. Belatacept, the PTLD risk appears similar to that of CNI. Belatacept is contraindicated in EBV seronegative patients based on two large phase 3 trials like BENEFIT and BENEFIT Extend. Overall, the data suggests that it is the cumulative dosage of immunosuppression rather than specific immunosuppressive agents that contribute to the risk of PTLD. And coming to patient age and transplant organ related factors, recipients who are less than 10 years of age and greater than 60 years of age were at increased risk of PTLD because younger patients mostly are seronegative for EBV and older patients have decreased immune surveillance. An analysis from Australia and New Zealand dialysis and transplantation analysis suggested that expanded criteria donor kidneys were also at increased risk of PTLD due to enhanced systemic inflammatory response. Genetic factors were also found to be associated, like HLA class 1 alleles like HLA-826, B18, B21, and B40, and the protective alleles are HLA-A3 and DR7. Pathophysiology of EBV enters the body through laryngopharynx and affects the submucosal B cells and establishes lytic infection in them. During the lytic infection, it destroys the B cells and leading to virion, more number of virion production, and then infecting the other naive B cells. Few cells express few latency type 3 proteins like latent membrane proteins, Epstein-Barr nuclear antigens, and Epstein-Barr encoded RNAs, which lead to the transformation of B cells into blasts, and activated B cell blasts are formed. And generally, cytotoxic T lymphocytes in immunocompetent patients suppress those blasts from proliferating. But here, in immunosuppressed patients, these blast cells pass through the germinal center and proliferate, and because of uncontrolled proliferation, it leads to development of PTLD. In EBV negative patients, various theories are present, saying that one among the theories EBV hit and run infection, and the other theory, they say that there is genomic transformation similar to immunocompetent patients. Clinical presentation, diagnosis, and staging. Presentation is variable, like they may present with non-specific symptoms like fever, weight loss, and fatigue, or they may present with dysfunction of the involved organs. PTLD has higher incidence of extranodal involvement. Frequently, GI tract is most commonly involved, followed by solid allografts and CNS. Early onset PTLD is frequently EBV positive and involves the graft. which is donor derived, whereas late onset PTLD is EBV negative and involves extranodal organs. It is most commonly recipient derived. And pathological examination for diagnosis, gold standard is histopathological examinations, and some supportive studies like immunophenotyping and screening for EBV by EBV encoded RNA in situ hybridization are also there. FDG PET-CT is helpful for diagnosis and staging. False positive results may be seen with infection and inflammation on FDG PET, whereas negative results can be there if it is allograft limited and if it is localized to CNS. And T-cell PTLD have low FDG uptake, so those can also be false negative. And PTLD, if it involves renal allograft, it involves renal allograft in 21% of patients, and they have polymorphous appearance. They have monotypic staining for kappa and lambda. It may also resemble T-cell mediated rejection, and where there is widespread mononuclear infiltrate invading the tubules and vessels. In PTLD, the infiltrate generally forms a dense sheet of monomorphic large lymphoid cells with prominent nucleoli without accompanying edema. Whereas in T-cell rejection, accompanying edema will be there and tubular cell injury will be there. Tubulitis will be there. The infiltrating cells in PTLD are positive for EBV in situ hybridization for Epstein-Barr encoded RNAs. The nuclei stain brown to black when stained for in situ hybridization for EBER. And here in slide A, there is dense mononuclear infiltrate in the interstitium. The cells also permeate between the tubules, but there is absence of tubulitis and there is absence of interstitial edema also. That can be helpful in differentiating from T-cell mediated rejection. Histopathological classification as per WHO 2017, there are 6 subclasses of PTLD, 3 types of non-destructive PTLD, plasmacytic hyperplasia, infectious mononucleosis like PTLD, and florid follicular hyperplasia, polymorphic PTLD, monomorphic PTLD, and Hodgkin's lymphoma like PTLD. Most of them are associated with EBV, that is EBV infection is seen in almost all cases of non-destructive PTLD, greater than 90% of polymorphic and Hodgkin's like PTLD, and half of monomorphic PTLD. The slide shows the staging. EBV viral load testing. So EBV viral load is measured using polymerase chain reaction amplification of EBV DNA from peripheral blood. In patients with PTLD, the viral load is higher than the patients without PTLD, and rapidly increasing viral load is also associated with increased risk of PTLD. The only drawback is there is lack of standardization of the cutoffs for EBV viral load testing. Prophylaxis, there are 2 approaches, that is universal prophylaxis or preemptive prophylaxis. Preemptive prophylaxis aims at monitoring the EBV viral load in high-risk patients within first year, especially because the risk is greatest. KDIGO recommends that EBV viral load monitoring is done in EBV seronegative patients who receive donor organs that are either seropositive or seronegative. Who are receiving the patients who receive organs from seropositive donors, weekly to bi-weekly monitoring is done until first year of transplant, and who receive from seronegative donors, monthly monitoring will be sufficient. The cutoff value for EBV DNA is difficult due to lack of standardization, as already mentioned, and the quantification of EBV specific cytotoxic T lymphocytes is also being used using the HLA tetramers and enzyme linked immunospot assay. So for preemptive prophylaxis, the interventions required are: first, we reduce the immunosuppression to allow for development of EBV directed immune response. Then antivirals were tried, but the benefit is uncertain. In a systematic review and meta-analysis also, which was published in American Journal of Transplant, it was found that there was no effect of antiviral prophylaxis over incidence of PTLD.
Tanvi, sorry to interrupt you. Can you wind it up for the list?
Sorry, sir.
Can you cut short it?
Okay, sir.
Because we need to give room for other speakers also.
I'm trying to be fast, sir. Okay.
Sure.
One more modality is adoptive immunotherapy, wherein expanded autologous cytotoxic T lymphocytes or donor polyclonal EBV specific cytotoxic T lymphocytes have been used. Universal prophylaxis, there is no data supporting the role of antivirals as such, and effect of CMV specific IVIG was also did not show any benefit when given along with antivirals. Treatment, mainstay of treatment is reduction of immunosuppression. And first is stop antimetabolites, that is azathioprine or MMF, reduce the CNI by at least 50%. And for critically ill patient or who have life-threatening disease, we have to stop all the non-glucocorticoid immunosuppressants. We restage the patients within 2 to 4 weeks and look for response. And graph monitoring should also be done to look for rejection, because 37 patients had rejection when we reduced immunosuppression. And lack of response generally seen in EBV negative patients or bulky disease or advanced stage 3, stage 4, and older group patients. Modality is rituximab. Rituximab is generally given weekly for 4 weeks, 375 milligram per meter square, and mostly 44 to 79% of patients respond after reduction of immunosuppression plus rituximab, and the persons who respond partially, 4 additional rituximab doses can be given every 21 days. Next is chemotherapy for patients who don't respond to rituximab and reduction of immunosuppression. That is CHOP regimen, cyclophosphamide, doxorubin, vincristine, and steroid. There are 2 trials based on this, PTLD1 trial and PTLD2 trial. PTLD1, the extended part says that we have to give rituximab weekly for 4 weeks, 375 milligram per meter square. Then the patients who respond can be given 4 more doses of rituximab every 21 days. And the people who don't respond, we straight away go for R-CHOP regimen. PTLD2 trial tried rituximab, they gave rituximab subcutaneously along with R-CHOP regimen. Newer therapies, adoptive immunotherapy was used in EBV positive PTLD, where partially HLA matched EBV specific cytotoxic T lymphocytes were studied, and in which 46 patients were treated with rituximab refractory PTLD were treated, and complete or partial response was seen in 54% of patients. The other new modality is brentuximab vedotin, given in refractory or relapsed CD30 positive lymphomas. Thank you.
Thank you, Dr. Tanvi.
Well, that was an extensive, that was an extensive presentation. And I think you've covered all the data rather very much in detail. The bottom line is PTLD is rather common in our situation, but as you rightly mentioned, amongst the various solid organ transplants, it has the lowest incidence. However, because the number of renal transplants done all over the world is the maximum, it's a significant burden. Your cases were very interesting and it showed very nicely. There is a lot of questions in the chat box. I can see that whether we do Epstein-Barr virus screening. At least in Apollo, we are not doing it. I'm not sure whether the others are doing it too, but I think it is something which can be done and definitely would be helpful. If there is a donor and a recipient mismatch, we should do it, maybe not as frequent as the KDIGO guidelines, but at least to understand what it is. Just without taking more time, a couple of things. Coming to the ATG, why the incidence of PTLD was increased, it has been found that trials done later use much lower dose of ATG, and that is why the possible reduction of incidence of this PTLD has happened. Nowadays, one interesting thing is, it is being said that acyclovir and ganciclovir, which we use regularly as prophylaxis for CMV, may have a role in reducing the PTLD incidence. Of course, pediatric kidney transplants are much more prone than adult transplants. And I think, as rightly mentioned, reducing immunosuppression, rituximab, and in those resistant, CHOP would be the way to go presently for us. Over to you, Srikant.
Sir, Dr. Ratan Jha, any comments, sir?
It was a very nice presentation of the PTLD case. We had a kind of publication in this regard. We published it in way back in 4 years back in Indian Journal of Nephrology. Our experience of malignancy over 26 years, and we found that in the first decade of this malignancy, the commonest malignancy was this PTLD, and subsequent to that, in the second decade and beyond, PTLD was not common, and it was more of a epithelial malignancy. And we found tongue carcinoma as one of the things which was not reported anywhere in many series, etc. We speculated that there may be many local factors, including viral infections. We know that many viral infections produces the risk of infection, like hepatitis B, hepatitis C, CMV, all of them are linked to malignancy. Even the Helicobacter pylori, also bacterial infection, is linked to a kind of gastric carcinoma. And HPV, viral infections are also mentioned to be linked to many of the malignancies. So probably in our context, I have a belief that probably infection is a trigger factor, and in immunosuppression maybe a link when we are giving over immunosuppression in our patient based on the Western data of the protocols, probably the incidence of malignancy can increase. We found roughly around 5% of patients over the follow-up developed malignancy. It was not a very common kind of thing, etc. But PTLD was the commonest, which is reported everywhere in the world. That is 20% of total malignancy is PTLD, and the remaining things are epithelial. So Epstein-Barr virus, we have in our series of 5 patients where we had this infection of PTLD. We did in situ hybridization because that was not available that time, the serology, and we found all of them were negative. So we had all maybe the Epstein-Barr virus negative late onset PTLD. So there is a role, but probably in our country, whether to do those kind of serology as well testing is always looking interesting, but very difficult to practice it. So most important thing is how to follow screen for these things. So whenever we have a kind of unexplained symptom of weight loss or fever unexplained, probably this possibility should be always looked at, because before we think that it is only infective. So most of the patients that we saw in our PTLD were having weight loss with fever. And so that is the clue that one should always look at in the clinical examination, a weight check on a regular basis to see is there anything has changed or not. We found most of the PTLD to be extranodal. We didn't find even a single patient who had graft kind of PTLD or even a lymph node PTLD. So it is more like a non-Hodgkin's type of presentation of in the post-transplant, which is called PTLD. So because now we are not having the term non-Hodgkin's, it is all called lymphoma, and Hodgkin's lymphoma is a different subtype that is there in PTLD. So the presentation that was made actually is over so many 3 decades, they have found only 6 cases. So it is not still a common disease in India. We find most of the patients succumb to other problems, and that's why they do not develop malignancy in our country. Back to the organizers.
Yeah, thank you, sir, for that excellent comments and feedback. There's a lot of discussion on the chat box regarding whether screening is required, and most of the seniors are of the opinion that screening should be regularly incorporated, particularly if the transplant is for a pediatric patient. Screening should be regularly incorporated. Without wasting any further time, we move on to the second talk. Dr. Praveen, anything else to comment, or should we go on to the second talk?
Nothing, sir. Proceed, sir. Second.
Yeah, so this is a talk on nephrotic syndrome in pregnancy by Rana Fatima madam, and the chairpersons will be Dr. Urmila Anand will be the chairperson. Over to you, madam.
Dr. Srikanth, Dr. Urmila and myself are both unfortunately in ISMCME meeting. So I would request Dr. Swandaka to take over.
Yes, ma'am.
Dr. Srikanth, as Manisha says, I am also in a meeting.
Okay, ma'am.
Let Swalata take over, but
sure,
we'll try and go through the me as much as possible.
Okay.
Thank you.
Yeah, I think I mean both chairpersons Urmila madam and Manisha are busy, so I think our moderators are competent enough to take over. So I request them to continue with the proceeding. I request Rana Fatima to please start your nephrotic syndrome in pregnancy.
Dr. Rana madam, please share your slides.
Right. Fatima.
And of course, I must now introduce the new chair of this committee, who is Manisha Sahay. Manisha.
So Rana Fatima, in fact, we have studied together. She was my junior in Tirupati when she was doing MD General Medicine, and we have been colleagues. And I would love to hear to her, Rana Fatima, please.
Yeah. Good evening, everybody. Greetings from Pratima Institute of Medical Sciences, which many people must not be knowing about this from Hyderabad. This is a private institute. It has 1100 beds and it is present in the suburb of Karimnagar. There's lots of fresh air. It is present among the paddy fields and it's a very peaceful environment to work with and it's a patient-friendly environment also. So first I thought I'd introduce about my institute, then I'll talk about the case. And I would like to thank Dr. Sonata for allowing me to present in this forum where all my teachers are present. I'm especially thankful to her for that. So as was said, this is a nephrotic syndrome in pregnancy, but there are certain atypical details about this case. So we know what is atypical about this as I go along the case details. So this patient is a 30-year-old second gravida who had pediatric from 12 weeks of gestation. So at the third month of her pregnancy, she started developing pedal edema, which was insidious in onset and gradually progressed in severity. Within 2 months, she noticed that she has developed facial puffiness with abdomen distension. So that was the COVID time. She had this video call with her gynecologist, who said that probably it is gestation related. But within 2 months, when the weight gain was around 12 kgs, they got worried and the patient was referred to nephrology department. So when we reviewed the history, she had froth in the urine. There was no hematuria or dysuria, and there was no shortness of breath. There was no history of similar complaints in the past pregnancy, which was 7 years back. There was no history of PIH in the past pregnancy. She never had any medical illness like kidney disease or heart disease. She definitely had secondary infertility for which she had taken treatment, but no specific cause was identified for that. She had no recent history of fever, sore throat, or rash or joint pains. Systemic examination was normal except for this anasarca and pallor. Her blood pressure was documented to be normal. Investigations showed anemia, and urine analysis showed proteinuria, which was nephrotic range proteinuria. Renal function test was normal. She had hypoalbuminemia with hypercholesterolemia. We had done the serum ANA, it was negative. Complement levels were also in the normal range. Ultrasound examination, ultrasound abdomen showed gross ascites with bilateral increased parenchyma and echogenicity to the kidneys. Fetal scan was it was normal with viable single fetus. So provisional diagnosis of early nephrotic syndrome in pregnancy was made because it has started in the first trimester, and it was probably due to primary glomerular disease. Kidney biopsy was not done. There were 2 reasons. First, the family also refused, and second, we also thought because it's only she had this mild to moderate nephrotic syndrome without hypertension, and renal function test was also normal. Therapeutic trial with prednisolone was started, thinking that it is a primary glomerular disease with 1 milligram per kg per day, and this dose was rapidly tapered to 10 milligram. Aspirin was also added to prevent preeclampsia along with adequate calcium and iron supplementation. She required loop diuretic furosemide for a short duration to control edema. She improved symptomatically and she was coming for subsequent antenatal visits, but she continued to have mild to moderate proteinuria. There was normal blood pressure and kidney function tests fortunately were normal in subsequent antenatal visits. How she landed up in ER at 35th week of gestation. This time she had this shortness of breath along with headache and blurred vision. For the first time, she was documented to have high blood pressure. It was 150/90, and investigations showed anemia and active urine sediment. RBCs were there along with proteinuria, and creatinine was elevated, and blood urea was 69. Creatinine was 1.3. She had this hypoalbuminemia, cholesterol levels were elevated, and uric acid was 11.8. Liver function tests were also mildly elevated. Ultrasound abdomen showed enlarged kidneys with increased echogenicity and loss of CMD, and fetus of gestation age of around 31 to 32 weeks. 31 to 32 weeks, so it was small for gestation age. She had presented 35th gestation, but the fetus had gestation age of 31 to 32 weeks. Fetal Doppler showed evidence of raised indices in uterine and umbilical artery, which was suggestive of uterofetal placental insufficiency and IUGR. So a diagnosis of superimposed preeclampsia with acute kidney injury was made, along with IUGR and underlying nephrotic syndrome due to primary glomerular disease. She was started on antihypertensive, methyl dopa, and labetalol. along with Maxell therapy, and steroids were given parenterally. Emergency section was done because the symptoms continued to become more severe. A live male baby was delivered with a birth weight of 1.36 kg and Apgar score of 7. Postpartum period was eventful both for mother and the baby. Baby had sepsis with respiratory distress and neonatal jaundice and was in hospital for next 3 weeks. Mother also suffered in the post-operative period. She had severe ascites with excess drain output. It was almost 500 ml to 750 ml per day. She had this wound infection and urine infection. We repeated the investigations. She had again persistent hypoalbuminemia with proteinuria. Based on the clinical picture and this persistent abnormalities, we decided to give her intravenous cyclophosphamide along with IV albumin and combination therapy with diuretics. There was significant symptomatic improvement over the next few days. She was discharged almost after 3 weeks of admission, and at discharge, she was given oral steroids along with, she required 3 antihypertensives, which included ARBs, and she also required diuretics. She was seen 2 months postpartum in Nephro PD with persistent ascites, hypertension with active urine sediment, and normal renal function test. So this time we planned renal biopsy for her. Biopsy was done and it showed 7 glomeruli. All glomeruli showed this proliferative picture with significant subendothelial deposits. This was light microscope picture, forming wide loop lesions in the majority and highly thrombite. There was moderately dense infiltrate of lymphocytes. IF showed 5 glomeruli with significant peripheral and mesangial deposits. There were 3+ of IgG, IgM, C3, C and C1p and kappa and lambda chains, which was almost full house deposits. The features were diagnostic of class 4 lupus nephritis with moderate activity, 1124, and no chronicity. After we got the report, we repeated her ANA profile. This was done 3rd time. So first, initially when she had presented and during admission when she was in the hospital, and again in just after biopsy, we repeated the sample by IF method. It was negative the 3rd time. I consulted a rheumatologist and pathologist. Again, opinions were taken. There were no features of extrarenal lupus. And finally, a diagnosis of ANA negative lupus nephritis was made. After this, she received monthly once cyclophosphamide with steroids for next 3 months. However, we had to stop cyclophosphamide because she developed this esophageal candidiasis once, and next month she developed this pneumonia. So we had to stop cyclophosphamide and start her an MMF, which she tolerated really well, and she was stable for next 18 months with stable clinical and biochemical parameters. Or after 18 months, again, she was admitted with a lupus flare. It was nephritic syndrome presentation. This time her serum ANA levels were elevated and repeat biopsy was done, which showed class 4 lupus nephritis. So in the next slides, I will be discussing the atypical features of this case. Nephrotic syndrome in pregnancy, the most common cause of nephrotic syndrome in pregnancy we all know is preeclampsia, but most common cause in early nephrotic syndrome is kidney pathology. Other possible causes of early nephrotic syndrome, which are less common, are preeclampsia, particularly preeclampsia if it is associated with abnormal pregnancy. This abnormal pregnancy may be in the form of molar pregnancy or pregnancy associated with chromosomal anomalies. Very rarely, rarest of the rare case, still preeclampsia may present without hypertension, just as nephrotic syndrome in first trimester. There are case reports of such presentations where preeclampsia is presented as nephrotic syndrome in the first trimester. So this slide I made for students. So this is a very interesting slide in which I have summarized all the details of the previous one. So most common cause of nephrotic syndrome in the first trimester is kidney disease. Renal biopsy is to be done only when it is indicated, when it is massive nephrotic syndrome, when the renal function test is deteriorating. So then only renal biopsy is indicated. Otherwise, most commonly, we go with therapeutic trial with steroids. In severe cases, once we have done biopsy and we know the disease is severe, then we can add on cytotoxic agents in the form of azathioprine. And if the patient is not tolerating that, we can go for CNI. So this is a common case scenario. But sometimes before we go ahead with biopsy or start with immunosuppression therapy in this patient, which are precious pregnancies, we have to rule out abnormal pregnancy. This can be done simply by doing a fetal scan, which was done in a patient, and doing serum AFP levels and serum beta HCG. Nowadays, all gynecologists are screening pregnant patients with serum AFP levels and beta HCG, alpha fetoprotein levels in beta HCG. You have to check the records whether this has been done. If this is abnormal, it means the pregnancy, it is associated with abnormal pregnancy, and this in turn has caused preeclampsia and this nephrotic presentation. Again, I'm saying these are all atypical presentations. So once this is the scenario, then the treatment is termination of pregnancy. There's no role of steroids. So in first trimester, the patient is presenting with nephrotic syndrome. We should ask for fetal scan, serum alpha fetoprotein level and beta HCG level to rule out abnormal pregnancy, instead of immediately going with therapeutic trial with steroids or planning biopsy. In the rest of the rare case, I said preeclampsia with normal pregnancy may present as nephrotic syndrome in the first trimester. There are certain case reports you can see on it. This can be identified by ratio of SFLT1 by placental growth factor. These are specific markers for coming from the placenta. These are elevated in preeclampsia. So this will be elevated. Here again, because the preeclampsia is presenting very early on in the first trimester, there's no point in continuing the pregnancy and putting the mother's health at risk. Most of the times, the gynecologist may opt for going for termination of pregnancy, and definitely there's no role of steroids. So any case with nephrotic syndrome presenting the first trimester, ask for a fetal scan and serum AFP levels, beta HCG and SFLT by placental growth factor. If all these things are negative, we can plan for biopsy, which is preferable. If biopsy is not done, then we can give therapeutic trial with steroids. Assuming my case was a lupus nephritis in pregnancy and not giving much importance to the seronegative state of that. So renal, if I have done biopsy in this patient, I would have added probably cytotoxic therapy in the form of azathioprine and would have led to better obstetric and renal outcomes, because this mother, she had preeclampsia, she had preterm delivery at 35 weeks, she had IUGR, this all could have been avoided. Now, lupus and pregnancy, they both are unique clinical situations in which in one individual, two altered immune states coexist. One is physiological, one is pathological. In physiolocal immune status, we should assume the fetus to be a semi-allograft, in which the outer cell mass, which we have learned in embryology, which consists of cytotrophoblasts and cytotrophoblasts, these are the fetal cells that are invading the mother's endometrial lining, which is now labeled as decidua. So as the fetal tissue is entering, it is like putting a transplant there. As it is entering, the fetal cells are shed, fetal antigen is shed, and there will be an immune response which will not allow placentation. So for that, at the maternal fetal interface, there should be a suppression of the immune response. This happens as a result of activation of the Treg cells. And there's an important shift which is happening of the helper cells from TH1 to TH2. This also helps in successful placentation, because so many things are happening in the mother's body immune system. This makes a individual susceptible, if they are having the tendency for the lupus to precipitate for the first time in pregnancy. Like this graph explains us that during pregnancy, there's complete alteration of the immune system to allow the fetus to get implanted, for the pregnancy to continue, and at the right time, delivery to be done. So there are numerous changes which are happening here. Some cells are getting activated, some cells are getting suppressed. So ultimately, this an environment is created in which the fetus can easily survive. So some things are stimulated, some things are inhibited. All these things are done under the effect of hormones, estrogen, progesterone, prostaglandin D2, because a balance has to be achieved in which at certain levels, the immune system should be suppressed, but still the mother should have adequate immune maternal response to fight against infections. So for that, an adequate balance has to be achieved. So it's a completely different state. And in this state, if again, SLE gets precipitated, the patient has to face that burn. Now, so pregnancy and even this postpartum state, this is also a difficult time, may precipitate lupus. Not only that, there will be concordancy or discordancy between the clinical disease activity and the laboratory indicators. It becomes very complicated. What is physiological? What is pathological? What is the superimposed complications like preeclampsia? To differentiate that becomes difficult clinically. This slide shows us, not once we label it as a lupus in pregnancy, it becomes a precious pregnancy because the chances of fetal loss is higher. The decidua, as I said, is endothelial lining endometrial lining, which is known as residua. The blood vessels there, they're inflamed in SLE, and antibodies are generated against trophoblasts. This may lead to fetal loss in SLE. And we all know about anti-Ro and anti-LAR antibodies causing fetal effect on fetal cardiac conductive system, and APLA causing ischemic pregnancy loss because of the placental ischemia. So correct diagnosis may avert increased fetal loss in SLE. So for correct diagnosis, we need to have serology or renal biopsy backup. A similar case report was presented in Lupus Journal in 2005 by Ozdemir. She says that there was a seronegative SLE which presented as nephrotic syndrome in early postpartum period. So diagnosis of seronegative lupus nephritis is usually done in the background of nephritic or nephrotic syndrome. You have done the serology, it is negative, and biopsy, the pathologist is giving a picture of full house nephropathy. Now, what are the possible reasons for seronegative status is, usually these are technical reasons, like that patient, that particular individual is having probably low levels of serum ANA. This may be because of the nephrotic state, severe nephrotic state, there's a loss of immunoglobulins in the urine, or you have started very high dose steroid therapy, which has suppressed at that time antibody production. There may be technical factors like antigen deficiency in the substrate used for ANA assay, or inadequate method of fixing causing leaching of antigens. So these are all confounding factors. Very good commentary by Cross, in which he has explained very well about the seronegative lupus. He says whether does it really exist? He questions that. Are these confounding factors? So what is the reason why? Because on follow-up, most of the patients develop this extrarenal symptoms, or they're developing positive serology. So he questions that probably it does not exist. When initially this was identified, the seronegative entity was identified, it was when they were using other cell lines like animal cell lines to test this. Now, when you're using human epithelial cell line, the negative rates have drastically come down. So he thinks, so according to Cross, he says that probably this entity doesn't exist and it is rarest of the rare to exist. And the clinical course, when they have followed the cases, most of the cases have become positive, or they have developed extrarenal symptoms of lupus, and they behave similar to seropositive cases. Another perspective of looking about this full house nephropathy is non-lupus full house nephropathy. This article is from Indian Journal of Nephrology, in which they have analyzed non-lupus full house nephropathy patients, and they have followed over a period of time. These patients did not develop, again, clinical signs and symptoms of extrarenal lupus, nor did they develop positive serology. Out of 500 cases, they were able to identify 80 cases which continued to maintain their seronegative status and clinically negative and the negative about lupus. And most of these patients were membranous nephropathy cases and IgA nephropathy cases. And they say, the authors finally conclude that do not label unnecessarily these patients as lupus. So it's something like when you're, it's a divided opinion. Is seronegative renal limited lupus a true negative entity, or is it a false positive entity? Is it wolf in sheep's clothing or sheep in wolf's clothing? Is it really lupus or it is not lupus? But all these articles, when we review all this data, ultimately everyone gives the point that whenever a patient is presenting, whatever be the LM picture, whatever be the serology, whenever there's a full house nephropathy, there's poor renal survival. So I think we should go ahead and treat the patient as a case of lupus nephritis. Means you should go for combination therapy along with cytotoxic therapy, induction and maintenance therapy for a prolonged period. This is a highly recommended reading, this by Anne Mary. They have said about the practical challenges which you face when you are managing nephrotic syndrome in pregnancy, very well covered. Students can take this reference. It has come in Obstetric Medicine 2011, in which very beautifully they have divided what challenges at every step you have in managing nephrotic syndrome pregnancy. It is like transplant patient. In transplantation also, we say the epidemiological data is very positive, but every case again is unique. Similarly, every case of pregnancy with nephrotic syndrome is unique, and there are certain challenges which I have just summarized here. First of all, there may be diagnostic delay, as was seen in our case, because of the overlap with the physiological parameters, hyperbulimia, hypercholesteremia, which may be physiological. Then the physician has to decide whether to do biopsy or not to do biopsy. Management of nephrotic syndrome itself is become problematic because we cannot use spironolactone, we cannot use statins, we cannot use ARBs, which are the cornerstone therapy there. And again, what cytotoxic agents are to give? We have to be giving only azathioprine, CNI, other all agents are contraindicated. Nephrotic syndrome per se is associated with increased obstetric complications irrespective of the underlying kidney disease. Then this itself, the pregnancy status itself may cause deterioration of the underlying kidney disease and may make the clinical situation more complex. As we know, nephrotic syndrome is associated with increased incidence of infections, anemia, and calcium deficiency. We have to give adequate supplement. To handle such situations, we should connect with a gynecologist, and if the rheumatologist is there with him also. An experienced team should follow, and the patient should be followed with frequent and planned visits. We should anticipate every trimester what problem may happen and investigate the patients adequately in every trimester. So definitive diagnosis of early nephrotic syndrome in pregnancy is to be done by using appropriate tools. And which tool is important for what patient depends on the clinical presentation. Again, a patient who has known case of kidney disease will not go for all the other tests. Yeah, lupus nephritis may present for the first time in pregnancy as nephrotic syndrome. This was a recommendation by ISN RPS study group. It states that the renal biopsy findings must be interpreted by the referring clinician in the context of the patient's entire clinical presentation, including serological findings. So there's so much wisdom in this statement. Thank you.
Thank you, Dr. Ana Fatima. That's an excellent case and a very difficult case to manage.
Yes.
You have managed definitely the case very well and saved the patient from many complications. The primary diagnostic dilemma, the primary dilemma that you had probably was regarding deciding regarding the biopsy. I think that remains a controversy, but I think Manisha ma'am is back. She has commented in the comment box. I request the seniors to comment on their decision primarily regarding how to go about doing a biopsy when a patient presents with nephrotic syndrome.
Can I comment, Shrikant? Yeah, I think it was very well managed, and Fatima, you have covered the literature also very well. So most of the time we see SLE presenting as a complicated pregnancy, or might be diagnosed SLE because they present with the multiple abortions, complicated pregnancies. So it's unlikely that they are present early in the pregnancy with nephrotic syndrome. We've also seen cases they present, in the late pregnancy or postpartum HUS and then the AKI, pregnancy-related AKI. So this is a little unusual case, though probably the other centers like, Usmania Gandhi, where they have pregnancy, complicated kidney diseases referral. So probably they might be seeing more such cases, but with us, we rarely see such situations. And as you have rightly pointed out, doing a when to do a biopsy, it's it's a very pertinent question. Initially, I think first trimester and second trimester we can safely do a biopsy, but before we can doing a biopsy, we can always treat with the steroids. If they are not responding to steroids or is behaving, unusually, or going in for, the nephritic or hypertension and going in for a renal failure, that's when we can go for a biopsy. So luckily, she has responded very well till, third trimester. That's quite unusual, particularly in a pregnancy. We see and they end up in the abortion, or they end up with a renal failure in the second trimester itself. So luckily, the patient fared well till the third trimester, and then where she presented with emergency, and then the the emergency Caesar was done. And coming to the second point, what she has pointed out is the non-lupus full house. We quite often see such patients, and we are in a dilemma whether to treat aggressively or not. So what we have learned over a period of time, and with the review of literature, what she has presented is sheep in a wool or wool in a sheep. So they behave little benign. So we don't have to treat aggressively, because they end up in having infectious complications. And we have started, reducing the immunosuppression. Just we give immunosuppression for 3 to 6 months, and subsequently have very close monitoring of these patients. So that's my take on this. And once again,
I just want to know, what is the method by which you tested for ANA?
Immunofluorescence. IF.
IF and initial twice it was negative and third time it was fourth time it was
Fourth
positive.
time it was positive, madam, and patient presented with nephritic syndrome.
Because it's very unusual, because they say if you have done by IF and if it is not positive in a 1 in 80 dilution, then it is not lupus, and then you will say non-lupus full house full house IF glomerulonephritis.
Yes.
For which there is no specific treatment.
Yes, but most of the patients which were followed the seronegative cases, most of the patients over a period of months to years, they develop they become seropositive.
Because I don't know whether this, at least the Manisha or people who are in academic centers should correct me, that is there still this entity called an ANA negative lupus?
Madam, actually, you are the principal academician of Usmania. So you were in an academic center and we are all your students. So I'll correct you there first. So apart from
Manisha, you lost your voice.
I think we lost Madam's
You
connection.
lost your voice?
Yes, ma'am.
Ma'am, good evening. Meanwhile, I'll make a comment about the renal biopsy. There is a recommendation actually, I think Mike has posted a bit about that. I'll post the link shortly. There is a one nice guide about it can be done if there is a benefit of, if the treatment strategy is going to change, if the clinical management is going to change, then probably the biopsy may be suggested in the first and early part of second trimester of pregnancy. So, and also, as we know, it needs to be done in ultrasound care and by experienced physician. So this is one aspect. The other thing, madam, you are telling ANA negative. I think, as has been said, if the methodology is accurate enough, say that it is a seronegative lupus, now called, I think Fatima has already projected that non-full house lupus nephropathy. Basically, the emphasis is regarding the follow-up. At the point of time of presentation, probably the serology is completely negative, but these patients need a definitive follow-up because they may evolve over a period of time into some other immunological disease. So, the number of cases that have been reported in Indian Journal of Nephrology in the recent publication 2020 is also high. So there is an entity that we have to accept, ma'am, like a non-lupus full house nephropathy, serological negative, clinical negative, but full house on the biopsy slide. So these are the couple of comments that I wanted to make.
I think Manisha
ma'am, from here, Dr. Manisha here, just wanted to, second what Dr. Manjusha said, and I would just like to correct Madam. She said academic institute. Madam was a teacher in academic institute. So I think she has also seen a very good number of cases. And lupus in pregnancy, Dr. Rana has done an excellent job. And we many times see such cases where we have full house on the biopsy and during follow-up, we get ANA positive. We should always assure that ANA is done by immunofluorescence on HEP2 cells. 95% of the times it's sensitive, but still again 5% you have negative. These may be true negatives, but 90% of these cases on follow-up, they tend to develop either a low complement or serological positivity for lupus. So that should be kept in mind. And as I've put in the chat box, that article in BMC Nephrology 2019 is excellent. It's mentioned all the practical points about use of antiplatelets, when to use anticoagulants in pregnancy. So I think all of us should go through it once. Excellent. Thank you. And thank you, Rana. Excellent case.
Thank you, ma'am. Thank you for your comments. If there are no further comments, we'll move on to the third case. So for this, the chairpersons are Dr. Sribhushan Rajgaru and Dr. Manjusha. I think both of them are already on board. So the case is on unmasking the thickened membrane in diabetes. Over to the chairpersons.
Yeah. Hello, am I audible?
Yes.
Yeah, Dr. Mukesh. Welcome, Dr. Mukesh. I think a very good opportunity for me to introduce you. You are under Dr. Bhushan. So please go ahead with your interesting case scenario presentation.
Yes, ma'am. Good evening, everyone. Myself, Dr. Mukesh, senior resident, Department of Nephrology. So the title is masked nephropathy. So I'll be coming directly to the case. My patient is a 63-year-old male patient named VV. He's a resident of Warangal. He's a type 2 diabetes from last 10 years and he's on oral hypoglycemic drug and the sugars were well controlled. Patient is hypertension from 4 months and he is on amlodipine 5 mg and metoprolol 50 mg. There were no other comorbidities. So coming to the chief complaint.
And we all know that her body works with it. Is the full screen, no? Yeah. The full screen. I'm able to see the full screen actually. Is there any problem in this?
Hello?
Yeah, please, Mukesh, go ahead. Dr. Bhushan, sir, can you mute yourself? Yeah, Mukesh, please go ahead.
So coming to the chief complaint, the complaint was generalized body swelling from 4 months, which was insidious in onset and progressive in nature. The swelling started from lower limbs and slowly it progressed till knee, and then slowly it involved all part of the body.
The body works
and the other complaint were breathlessness, which was progressive in nature, NYHA grade 2 to 3, and frothiness in urine. So, and coming to negative history, there was no history of decreased urine output, hematuria, or lower urinary tract symptom. No history of orthopnea, PND, chest pain, sweating, and palpitation. No history of abdominal pain, jaundice, vomiting, loose motion. No history of fever, chills, sore throat, and skin infection. There was no history of arthralgia, myalgia, and any constitutional symptom. There were no history of similar illness in the past. No history suggestive of CAD, CVA, TB, thyroid disease, or peripheral vascular disease. There was no history of diminished vision, tingling, numbness in the hand and leg. So patient was evaluated by a local physician in Hyderabad, and the investigations were blood picture, hemoglobin was 11, count WBC count 4800, platelet 1.8, complete urinary examination 3+ albuminuria with no active sediment. The renal function creatinine was normal 1.2. Sugars were well controlled. It was slightly on the higher side. HbA1c was 7.8, but patient records that usually his HbA1c is below 7. Coming to serum albumin, it was 2. 24-hour urine protein was 14 gram. C3, C4 was done. This other investigation was done to rule out any non-diabetic kidney disease. So the local physician did C3, C4, which was normal. ANA ANCA was done, which was negative. Anti-Plato-R was done, which was negative. SPEC was done, which was negative, and FLC ratio was normal. So the physician also did fundus examination, which showed no evidence of diabetic retinopathy. So outside renal biopsy was done to rule out non-diabetic kidney disease, as there were indications for the biopsy. So he went ahead with the biopsy, and the reason behind biopsy was adult onset nephrotic syndrome with massive proteinuria. The proteinuria was 14 gram to rule out any non-diabetic kidney disease, and as there were no evidence of microvascular complication of diabetes in the patient. So coming to the biopsy report, this was reported in Apollo. So the light microscopy picture was there were 8 glomuli and 2 arteries. 2 glomuli were globally sclerosed. The other remaining 6 glomuli, they showed thickening of the GBM and a mild mesangial expansion. The cellularity was normal. There were no segmental sclerosis or crescents. IFTA was just 20%. Arterial hyalinosis was also present, and artery was normal. Coming to IF, it was negative for immunoglobulin, complement, and light chain. So the kidney biopsy, the impression was given as class 2 diabetic nephropathy, as patient had mesangial expansion and GBM thickening. So patient was labeled as class 2 diabetic nephropathy, and he was treated with anti-proteinuric measure, and he was told to control sugar and BP. Patient for 3 months, he took the symptomatic treatment, but he didn't have any symptomatic improvement. So he came to NIMS for further opinion. On coming to NIMS, he was again re-evaluated and differential diagnosis was suspected in view of the following points. First, the patient had massive proteinuria, which was 14 gram. So, and there were no features of any microvascular complication. Renal biopsy was suggestive of class 2 diabetic nephropathy, but clinically it was not correlating with 14 gram of proteinuria. The biopsy, Congo red stain was not done in the biopsy. Electron microscopy was not done in the electron microscopy was not done, and pronase digestion was not done. So when he came to us, our main first diagnosis was MCD overlap. We want patient to be started on steroid, but already he was diabetic. So before initiating, before labeling him as MCD overlap, we want to go ahead with further test. Our other DDs were, it may be a amyloidosis, secondary amyloidosis, because kappa and lambda both were negative, and he didn't underwent any Congo red stain, and even on IF, SAA was serum amyloid stain was not done, and it may be some other glomerular disease. So patient was advised for Congo red staining in the tissue block. He was advised for electron microscopy to look for the food process effacement and pronase digestion on IF. So the tissue block was collected from the pathology department, and it was reported. It was the tissue block was sent, and it was reported. So this is the final impression of the electron microscopy. There was diffuse effacement of food process of podocyte. So we were thinking in terms of minimal change disease, but it was again showing that there were several subepithelial electron dense deposits which do not show any definite substructure on examination at higher magnification. There were no subendothelial, intramembranous and mesangial deposit. There were no TRI, and there were no extraglomerular deposit. So initially we thought it may be a MCD overlap, but in view of several subepithelial electron dense deposit, we thought it may be a membranous nephropathy. But since there was no feature suggestive of secondary membranous, there were no subendothelial or intramembranous deposit or mesangial deposit. Now our first DD was primary membranous nephropathy. So we went ahead with IF after pronase digestion, and it came out to be positive for IgG and C3. We could not do for kappa and lambda as tissue was exhausted, and even tissue plateau could not be done as tissue was exhausted. So our final diagnosis was membranous nephropathy with masked IgG deposits, and most likely it was primary in spite of serum plateau being negative, and tissue plateau we could not do. But it is very less likely secondary, as we did his autoimmune marker that were negative, hepatitis B, C viral markers were negative, and age-related malignancy were also evaluated, and PET-CT there were no evidence of malignancy. So we thought it is most likely a primary membranous nephropathy with masked deposits. So patient was advised, initially we thought we may give steroid, but since he was a diabetic, we didn't want to give any steroid. So we told him that we are proceeding with rituximab 500 mg 375 milligram per square meter once weekly for 4 weeks. But patient was not willing for rituximab, and he was lost to follow-up. Then, since the patient daughter was a doctor herself, we were in constantly touch with the patient attender, and we came to know that she had received rituximab in the private hospital. Exact dose and duration, but she is telling that around 4 to 5 doses of rituximab was given in the span of last 6 months. And as per attender, patient has responded partially to the treatment, and the 24-hour protein in January 2022 was 4 gram. Initially, it was 14 gram, and the serum creatinine is stable at around 1.2 to 1.3. So our final diagnosis was membranous nephropathy with masked deposit, and it was most likely primary since patient has responded to immunosuppression. Ma'am, shall I go ahead with discussion? Hello?
Please go ahead. Yes.
Yeah, ma'am. Coming to discussion, ma'am, membranous glomerulopathy with masked immunoglobulin deposit. Approximately 0.1% of the kidney biopsy shows this entity, and usually it is seen in women younger than 40 years. In contrast to classical membranous nephropathy, in which usually 75% of the patients they show nephrotic syndrome feature, and 25% usually subnephrotic range proteinuria or nephrotic range proteinuria. But in this entity, only 35% of the patients, they fulfill the criteria for nephrotic syndrome. And almost 1/3 of the patient, they will have elevated creatinine, renal dysfunction at the time of biopsy. And hematuria is almost 100% in this patient, whereas only one-third of the patient in primary membranous, they show hematuria. And almost half of the patient, they will have positive ANA. The autoimmune serology will be positive, but on further evaluating, they won't be meeting criteria for a defined autoimmune disease. Although this patient will have usually kappa deposits with IgG and C3, but when they are evaluated for paraproteinemia, usually it comes as a negative. So SPEP, FLC, bone marrow, they neither fulfill the criteria for MGUS or smoldering or multiple myeloma. So we don't know why, like they may be showing false positive ANA, and even the kappa deposit are not. It may be just a false deposit because on further evaluation, this patient doesn't fulfill the criteria for any paraproteinemia. And on further proteomic evaluation of this patient, it has been found that the proteins are usually made up of serum amyloid P component, which separates it from other membranous nephropathy. But it may be an incidental finding because there is no anti-serum amyloid P antibodies in this patient. And the optimal treatment is also not known, and the clinical course is unpredictable. It is not like a membranous nephropathy in which follows the rule of one-third of the patient will improve without treatment, one-third of the patient they remain static, and one-third of the patient they deteriorate. But most of the time in this entity, almost half of the patient they develop either complete or partial remission, and half of the patient they develop progressive renal disease, and almost 10 to 15% they develop end-stage renal disease. So coming to a case series, this case series was published in KI International, a Kidney International Journal in 2014 by Christopher P. Larson et al. So here the 14 cases, it is a case series of 14 patients in which on on LM it was not looking like a LM and IF, it was not looking like a membranous nephropathy. It was looking like either MCD or some other diabetic nephropathy. But when they went ahead with electron microscopy, there were large subepithelial deposits, and because of EM changes, they went ahead with Cronus digestion, and they found it to be mostly positive for IgG, C3, and kappa. These were the clinical characteristics of these 14 patients. Most of the patients were young. Their age was around second to third decade. Most of them were female. Most of them had normal renal function, and the proteinuria was also not like classical membranous nephropathy in which almost 75% present with nephrotic syndrome. Here, most of the patients were having subnephrotic proteinuria, and few of the patients they had false ANA positive, and almost all of the patients they had hematuria. So these 14 patients, when their light microscopy was read, almost these all patient biopsy was done in view of subnephrotic range proteinuria. So biopsy was indicated, and most of the time LM was normal. Most of the time the LM appearance was totally normal. Few had focal 1 or 2 present, and IF was negative. But because of EM changes, because of EM subepithelial deposit, retrospectively again they went for Cronus digestion, and we can see that almost 3+, 2+, IgG, kappa, and C3 deposits were there. And we can see that before this on frozen section, the IF was totally negative, but after Cronus digestion in paraffin tissue, it is fairly bright for IgG and kappa, and lambda it is negative. And electron microscopy also we can see that there are large subepithelial deposits, and most of these all patients were having primary membranous because this patient they didn't fulfill the criteria for secondary membranous. The deposits were only subepithelial. Thank you. Thank you, ma'am.
Yeah, I think that was a very nice case, Dr. Mukesh. You have brought out a very good concept of, of course, this has been described little earlier as well about, a decade back or something. I think you must have discussed about the Nasser et al. Study. He's the one who has, in fact, suggested about the concept of MGMID. So how was this patient treated eventually, and what is the follow-up, Mukesh?
Ma'am, this patient has almost received 4 gram of 4 to 6 doses of rituximab. This patient is not following treatment here, ma'am. He is being treated outside. Initially, we told him to take. Initially, he was not ready for rituximab because, and then after a few days he was ready, but he didn't follow to us. He is following outside in private hospital. But ma'am, I'm in constant touch with the attendant. The proteinuria has now become 4 gram, ma'am, from 14 gram. And even the serum albumin has improved. Now from nephrotic syndrome, it has become nephrotic range proteinuria. Even serum albumin is around 3.1, 3.2 ma'am now.
And basically the crux lies, generally going between the differences of a frozen immunofluorescence and a paraffin immunofluorescence. We need to know that in frozen immunofluorescence, obviously we tend to skip, or we probably have skipping of these IgG being absent. So there should be certain suspicion, especially with the availability of the electron microscopy. Maybe we are a little convenient. But then the paraffin, the pronase digestion of a paraffin fixed tissue is definitely going to yield or to show the mass deposits like this. So the advantage is much more in detecting the IgG compared to the other complements. So this has been well described in literature as well. So the final diagnosis, when it remains like this, the follow-up is better. You're saying that the patient is being followed up with the private hospital.
Yeah, ma'am. Now the
proteinuria has
4 gram. Initially 14 gram, now 4 gram.
Okay.
So we expected it to be a MCD overlap, because we were thinking it is an MCD overlap, and we have to give steroid or any other form of immunosuppressant. So we went with EM. So we were suspecting that if diffuse food process effacement is there, along with some diabetic changes, we will go ahead with immunosuppressant. But it came out to be some epithelial deposit. Then we went ahead with membranous workup.
Okay, what I mean to say at this point is, maybe if pathologist is also there, or anybody else can throw some light, because with the availability of the electron microscopy, we know that, I think retrospectively you have thought about, the possibility of an picking up an MG-MID with the pronase digestion. Pronase digestion was not done in this case at the outside, or even with us it was done, Mukesh?
Ma'am, pronase digestion was done outside, ma'am.
Outside, okay. So, that was before electron microscopy itself?
No, ma'am. After electron, before electron.
That's what I'm saying. That's what I'm saying. See, that's what we need to have, certain indications or suspicions, especially in such a scenario when the proteinuria is very high, massive, and it apparently is not yielding much of an information on IF. Probably it's better that we go ahead with the pronase digestion. There are particular methods steps which have been described for pronase digestion as well. And of course, complemented by the electron microscopy, we will be in a better situation for the definitive identification of the disease. In fact, this is crucial because our strategy of management is going to differ. The MCD will be definitely managed with steroids alone, but an MG-MID definitely has a different prognosis and different line of strategy of management. And it's very happy to know that, the patient has responded to the treatment. And is there any underlying secondary evaluation that was done, or anything that has come up over a period of time, Mukesh?
Ma'am, for secondary, ma'am, ANA was negative, hepatitis B, C was negative, and PET-CT age-related malignancy, he was worked up, it was negative. And on electron microscopy also, there was no extra.
No other deposits.
Yeah, so we thought, and moreover, he responded to immunosuppression. So we thought it may be a tissue plateau or negative. Serum plateau is negative. So it may be the 25% other which are other than plateau or some membranous nephropathy.
See, generally the tendency is, if plateau is negative, we'll ask for nowadays it's become a regular thing. We'll ask for the thrombospondin, what is that, semaphorin and all these things. But once electron microscopy is showing such a deposition, I think the doubt will continue. Instead of thinking about MG-MID, the presence of such subepithelial deposits in the EM, don't you think the evaluation for the other antigens should continue, because the array of antigens in the primary membranous nephropathy, in the membranous nephropathy, is increasing. Apart from the plateau, there are thrombospondin, semaphorin, protocatharin, which has been recently again identified. So these are not done in this patient, right?
Ma'am, these all, the Snell, exhaustion, these all were done in the tissue, and he was not willing for second biopsy. Serum we could do only FLAT2R, and he was not willing for.
That's right. Yes. Right. Yeah, good case presentation, Mukesh. Over to Srikanth.
Manju, how many doses of rituximab are being planned? Because already you say he has received 6 doses.
Ma'am, he has received 6 doses, ma'am, and he's telling that every monthly they receive 1 dose. And he's not being, we asked whether any CD19 count they are like checking before giving CD19.
Madam, I think Dr. Krishnan sir is managing this patient outside. Sir, if you are here, you can update about the follow-up, sir. Krishnan sir.
He's not at my regular follow-up. I did give him rituximab a couple of times, but I have not been following him up. I thought he has gone back to the primary consultant.
Praveen, what is the comment that you are trying to make, Praveen, to be sent to Mayo Clinic or something? What is this?
No, madam, nothing, madam. Actually, these novel antigens are now picking up, like as you said.
No,
like,
novel antigens, even Lalpak lab is doing, Alok Sharma is doing all this.
Lalpak is doing only 7A, madam. The other novel and like NEL1, exostocin 1 and 2.
He's doing, except for
novelties which are picked up by laser microdistant mass spectrometry. So
yes,
even novel
these are being done regularly. These are done regularly, Praveen.
Yes, madam. In the Mayo Clinic only.
No. What I'm saying, it's available with us in Lalpak lab. We have sent the samples from a public sector for all these semaphorine, NEL1.
I think he's talking about tissues.
I think they procured recently, madam, because previously they used
tissue sample only. Tissue sample only. Alok Sharma is doing for the NEL1 secondary things, thrombospondin, NEL1, exhaustive, whatever it is, 1, not exhaustive 2. Whatever, Manisha, thanks. 2 yes. Number he's not doing, but he's doing exhaustive 1. And protocatherine, of course, it's a recently available one. I don't think that antigen this thing is available with him. But till that line, he's doing. Alok Sharma is doing in Lalpak.
They are charging 3,500 rupees when they are doing.
नहीं उतना तो नहीं है. Who is speaking? मुकेश, उतना तो नहीं है क्योंकि हमने करवाए थे. मतलब इतना ज़्यादा नहीं है. I think it's less than 10,000.
Yeah. We also got it done.
It's not महंगा. इतना महंगा नहीं है. 35,000 तो नहीं मेरे ख्याल से.
3,500 rupees. 3,500.
मेरे ख्याल से it is less than 10,000 because we got it done. If it was such costly, I don't think we would have thought about it.
No,
anyway, nice case presentation.
Number of the antigens being done. This one probably is 10,000.
No, what he is doing is, see, if we are suspecting a membranous nephropathy and then we want a plateau serum is negative, tissue plateau is negative, you're thinking in lines of a secondary antigen, you can go ahead with the secondary antigen that is available with him. He will do NEL1, semaphorine, exhaustive 1. Apart from that, the subsequent thing he will not be able to do, but this is costing less than 10,000. This is what is my experience because I had got done for my patients.
I think, Mukesh, you can get it done for academic purpose, no? So, I mean, anyhow, they have the tissue now. So, I don't know whether we can subject that and get it done for academic purpose.
Yeah, ma'am, I asked, they are charging only 3,500 rupees, ma'am.
No, but now I really wonder, Mukesh, what is the relevance of going ahead with the secondary antigens because you have a membranous glomerulopathy with a masked this thing which has now become unmasked because of the pronase digestion. Are we not thinking it to be still a primary one? Do we still think it to be a secondary one in the background of a response and all these things? I think it's less likely.
Yeah, ma'am. That's why most likely it is primary only. That's why we didn't. He was not willing for second biopsy, and we thought anyhow he's responding. So. I think it is primary only, ma'am, because all the features and all the response to the immunosuppression, everything, it is favoring primary only. The treatment won't change.
Yeah, now we have the luxury of having electron microscopy even in the public sector hospitals. But then the pronase digestion is very crucial. But then when to do pronase digestion in the paraffin fixed samples is very crucial because that's going to reveal a certain diagnosis which are not revealed by the frozen IF. So, so that methodology, which has been found out about 1.5 decades back by this group of NASA, it has been a very significant element in extracting such such hidden diagnosis. But as of today, yes, we have the help of the electron microscopy, but literature is good with respect to this pronase digestion and unmasking the underlying IgG deposits, and especially when you use a pronase digestion, the IgG detection is about 100%.
Yeah, and there are indications also mentioned in literature when to go for a pronase. So I think that should be utilized more frequently.
Yeah, exactly. And of course, there are certain, clauses as to the outcome of pronase digestion, like depending upon the antigen that is used. We are speaking about pronase, but then there is a proteinase. There is some pronase 14 or something. So many antigens are there. And then, the type of the immunoglobulin that is detected, it's been said that it does not detect the complement. That means unmasking of the complement is not done with the pronase digestion. But the IgG can be detected in 100% way once you use a pronase digestion. So definitely certain indications are there. In corroboration with the pathologist, we should be able to do, especially, it will be much more useful in the resource limited settings where the electron microscopy cannot be done in for each and every case, and in the background of suspicion being high. Very good case, Mukesh. Dr. Bhushan is there? I mean, your mentor, Dr. Bhushan, comments, please.
Sir is ma'am going like one more program is going on.
अच्छा उनका साथ में आउट प्रोग्राम है ठीक है ओके
And ma'am
This patient
yeah Bhushan sir please.
Yeah, this patient was actually has come referred from other hospital, this doctor being a doctor, and we evaluated because of the non-specific presentation and unusual nature of not being so clear in a conventional immunohistochemistry or conventional immunofluorescence technique. So we had to investigate further also without of our curiosity and enthusiasm whether the patient has got any other etiology. And ideally, what you said is correct, that we should be able to check most of these parameters, not only the anti-PLAR2 alone, and we need to thrombospondin and then L1 and all other things also should have been checked in these patients. Probably in the future, all these patients might turn out to be something different totally and altogether, a different variety of membranous nephropathy. Interestingly, for the past few years, we have been seeing a lot of membranous nephropathy, which are very quite unconventional, and their behavior, the chronology and the clinical course of these patients with membranous nephropathy, we have been finding very non-specific and very vague. I think in the future, like the way MPGN has changed its turn, the FSGS has changed its modality, and the probably membranous nephropathy also will turn out to be probably a feature which we should be evaluated in a different perspective. Especially when we get so many antibodies that are being that are coming up in the literature now. So we are seeing minimal chain disease turning out to be membranous turning out to be minimal chain disease. The crescentic glomerulonephritis once upon a time has become membranous nephropathy. Something like that we have been seeing so many cases nowadays. Very interestingly, when we started doing second biopsies and biopsies later after a few years, when they come to us with unusual presentations. Similarly, these patients of elderly age group should be evaluated always for the malignancy, especially if they are more than 62 to 65 years of age group. But similarly, patients less than that age group should be evaluated if they have an unusual presentations and the manifestations. That's why we have done it. And the response to rituximab doesn't mean that it confirms primary nephropathy. It doesn't confirm the primary being it's a primary. But still, we need to look into this carefully and watch him closely with all the other manifestations. Unfortunately, the tissue got exhausted. We could not even do anti-PLAR in the renal tissue. But hopefully, if we can go for a second biopsy, probably we can check for the other antibodies being stained in them, because which are also available in our country now. Once upon a time, they were not available, probably that time. But now it is available in our country, with which we can actually stain and see whether it can portend a different prognostic disease condition in altogether when compared to the conventionally known membranous nephropathies. So that's what we are going to see in the future. And as for the management is concerned, I don't think there's any change in that. And rituximab is being given in a significant doses to him, and he's been responding favorably. And the only thing is that it's not just diabetic nephropathy alone, and we keep thinking about it, that diabetes and nephropathy equal to diabetic nephropathy, but diabetes plus nephropathy can be membranous or any other etiology, and we need to keep our options open and evaluate the patient and further explore. That's what I could learn from this case, but it's a very interesting case. But unfortunately, we are not following. We did not get the second biopsy in him. Otherwise, we could have actually done all properly.
I mean, yeah, having said that, Dr. Bhushan, whatever you have said is right. Absolutely. The understanding of the glomerular diseases is changing. That MPGN is a pattern of injury, FSJS is a pattern of injury. Now the membranous nephropathy has also joined the bandwagon of this understanding that membranous nephropathy is a pattern of injury, not the primary diagnosis. So obviously, having said that, we need to look into the etiology of the etiology of the membranous nephropathy, like searching for the antibodies. So with the availability of the antibodies, definitely we should be able to say whether it is primary or secondary. What I would like to emphasize is membranous nephropathy is also recognized as not a primary diagnosis on its own. It is being recognized nowadays as a pattern of injury. Hence, the etiology of membranous nephropathy needs to be thoroughly evaluated. But only thing, Mukesh, in this patient, the patient has responded to the treatment that you have given. So still, obviously, when the treatment is there, maybe you will be constrained to do another biopsy or something like that. But with the availability of the, the sample that is there, even if it is a formalin-fixed sample, which will have a lot of aberrations and all, the trial of doing an antigens can be suggested in case an affordability is there.
Biopsy is a tool in the whole armamentarium. It's not the final diagnosis. Because as Dr. Bhushan pointed out, you have different lesions in subsequent biopsies because biopsies represent.
Dr. Bhushan, please unmute, please mute yourself. No, Bhushan sir. Yes,
so I was
Manisha.
just, So I was just saying what you have said just now is very, very important because biopsy is an added tool in our armamentarium to manage the cases. It's not the final word. You have to take the whole picture into account, and with the antibodies coming up and all that. That's why you have so many different like variations in diagnosis once you do repeated biopsies in such cases where you are not able to come to a proper conclusion. So finally, the understanding is now getting more and more with the availability of these antibodies. So as you said, it's not, the diagnosis is not always given by the biopsy. It's just a tool, and we have to take the whole picture into account and keep on working to find out the etiology. And whether it involves testing for antibodies, I think we should go all out and do them.
Yeah, agree, Manisha. I think if the finances and if the availability is there in Lalpat lab, if the tissue is there, a formalin fixed and all, I think it needs to be done over a period of time if the patient agrees, because that at least will give us an idea. We are not dealing with secondary and we are comfortable in saying that it is primary, and go ahead with the same treatment, and of course understanding about the prognosis.
And like if most of the times if the tissue is available, we can go back and do some of them on that tissue.
Yes,
I think that was a very great discussion.
Can I just, ma'am, moreover, like this unmasking, there are few entities only where this unmasking is beneficial. Like one is membranous nephropathy, one is PGN MIDD, third is light chain proximal tubulopathy, and fourth is the MPGN pattern like C3 globulopathy, and on unmasking, it may be an immune complex. So usually for this commonly for this 4 or 5 glomerular disease, we are doing unmasking.
Thank you, Dr. Mukesh, for those comments. So the conclusion is that the glomerular diseases is moving away from a histopathological and morphological appearance to more of an etiological diagnosis. So that's where we are heading to. So before moving on to the giving the proceedings to the to Dr. Praveen, I request concluding remarks from Dr. Anuradha and Dr. Girish.
Now, before that, can we, discuss the first?
Yeah. Sorry, the first person.
Image of the month.
Image of the month. Yes, please.
Yeah, Dr. Nath, can you just?
Yes,
are there any answers in the chat box? Posted in the chat box? I don't see any.
No, ma'am.
Okay.
Neither in this the public, not only in this chat box, the other comment section.
Even the admin chat box also, there are no answers.
Okay. Okay, Wali, you proceed.
Nath, go ahead.
Yes, sir. So this patient presented with similar complaints both in May and October, that is 3 and 6 months post transplantations. And both time we went ahead with a pigtail drainage. The first time we kept the pigtail only for 3 days, and the second time an extended duration of 14 days was tried. The biochemical analysis of the fluid was normal, confirming it is lymph. The urea was 17, creat 0.5 with a lymphocyte predominant total count, and lipids were normal. Each time with pigtail drainage, his symptoms resolved and he was discharged. But he had a recurrence, third recurrence in January 2022, almost 11 months after transplantation. And this time again, the fluid had reaccumulated to 2 liters. So this is the CT picture showing a large lymphocele, which is hypodense, abutting the transplant kidney and pushing the bladder to the left side, compressing the bladder. So the treatment options are simple aspiration, prolonged external drainage, which we had already tried, and prolonged external drainage with betadine instillation. And if any of the members can comment on one more treatment option, which we did go ahead.
We commonly do for these recurrent cases marsupialization into the peritoneal cavity.
Yes, sir.
Which is
so this is the image. So exactly as sir pointed out, a fenestration of the lymphocele cavity was done, otherwise called marsupialization, where the lymphocele was opened into the peritoneal cavity. And this was done just 2 weeks ago, and now the patient is doing fine. So just a single slide on lymphoceles. It's a collection of lymph in non-epithelialized cavity. It is usually due to the division of lymphatics around external iliac vessels. So if the common iliacs are used, lymphoceles are less. And these days there is more detection due to graft USG surveillance. Small ones generally tend to resolve on their own, whereas larger ones will need treatment. Posterolateral locations are more common and near the lower pole of the graft kidney. So complications can be compression of bladder, ureter causing kidney dysfunction, especially after stent removal. The dreaded complication is the lymphocutaneous fistula, and very rarely it can cause compression of the iliac vessel and lead to DVT and ipsilateral limb edema. So this is a algorithm where any perigraft collection, if symptomatic and diagnostic of lymphocele, the initial therapy to be tried is a external drainage plus minus sclerotherapy, and it should be kept for maximum of 2 weeks for fear of infective complications. And if it still recurs, then we'll have to go for a laparoscopic marsupialization. And if still recurs, we'll have to go for a open surgery. Thank you for the opportunity. Thank you, ma'am and sirs.
Thank you. Thank you. That's a very interesting case that you presented. So I request concluding remarks from ma'am and Dr. Anuradha ma'am and Girish Narayan sir.
Good evening, everyone. I think I must say that our Nephro Forum meetings are becoming more and more interesting. Today, all the 3 cases were very good. The first one of lymphoproliferative disorders collected over a long period of time, and how they present, what is the relation to EBV, and what is the treatment options, and what is the long-term prognosis. Then, of course, pregnancy-related conditions we all see, but this was very interesting that lupus presenting so early in pregnancy as a nephrotic syndrome did not undergo a biopsy, was treated just with steroids, taken through a pregnancy, had post-pregnancy some complications, but then eventually diagnosed as lupus and has responded to treatment. And of course, the last case, very interesting case of a masked, membranous nephropathy with the masked immunoglobulin. All 3 cases were very interesting. And luckily for us, since it is a webinar, I think the participation should be very good. I think Somsundar should tell us what is the total number of participants, because all I can see is people with faculty link.
It is 100 at the current pace, madam. The people joined and left it. If I add, it will be around 120.
So that's because never in the history of offline, meetings at NIMS or anywhere else have we seen such a big attendance as we see in webinars. So really, Manisha, as you have said, it's a phenomenal participation, and I think this will occur only if it's a webinar, because we have seen if it is a meeting either at NIMS or
Ma'am.
I think Madam has lost connection.
Yeah, I think ma'am has, we have lost.
Madam has lost connection. I was thinking my connection is, I have lost my connection.
Girishna and
I also thought that only. I mean, I have some problem with it. Yeah, but congratulations, the whole team, I would say, as Madam already pointed out, phenomenal. I mean, 120 is a huge number. And these meetings and like this has been one of the silver linings of COVID. And these meetings are really helpful, and especially clinical case discussions. They are learning experience for all. Maybe everybody. Yeah, Madam is back.
Sorry, I got disconnected. So I am back. I think, Manisha, we all should agree that these meetings have been wonderful, and wonderful cases are being presented, and it's giving postgraduates so much of an opportunity to learn and discuss many new, unusual case discussions in this forum. It's becoming very, very vibrant, and I'm very happy about it.
Even the faculty, ma'am, as faculty also, we are learning from each other with excellent cases and very good work.
That's what I said, Manisha. We are also learning.
Yes.
I mean, after at this stage of my career also, I'm learning, because every day is a learning curve, and it's nice to learn something new in every meeting, and I'm enjoying it. Bali?
Madam, now I think we need to think about making it a physical meeting or a hybrid meeting or an online meeting, because obviously this virtual presence has made a significant impact on the number of audience, which we need to accept.
Yes.
So I am strongly of the opinion that we should have some form of online forum. Even though if you go physical also, we should have some form of online meeting so that we can accommodate our colleagues who are out of Hyderabad. At the end of the day, our motto is to stretch Hyderabad Nephrology Forum to cater the needs of all Telangana-based nephrologists.
Yes, actually, we are thinking to make it a hybrid. So we have already doing work on the background work on it. So hopefully we'll go for the hybrid in the next session. But little apprehension, because now we see so much of attendance online. And like we can see even Manisha, then Urmila Madam, and then even Bhushan sir was parallelly attending 2-3 sessions. So that is not
the best part of this meeting, the Swarna, is that 7 o'clock is a good time for us to join, because if it is a regular meeting, personal meeting, physical meeting, it will be around 5 o'clock. Usually it starts around 4 o'clock.
And we waste so much of time on the road, madam.
And it becomes very difficult for us to leave our work sometimes and then go and join these meetings. Although I must admit that we seniors have somehow found time to attend. But postgraduates and all, I'm sorry to say that the attendance from them has been very, very poor. So I think, Swarna, we should, I don't know whether it should be totally online or a hybrid meeting.
Madam, I fully second what you say.
Because again, I think COVID has come up in other China and then US. I don't know how it's going to evolve in India in next few months. So basing on that, preferably we'll go like live, like online only. So if possible, everything is clear, we can slowly start hybrid.
Yeah. Yeah,
ma'am, we can have maybe some physical, but mostly this format is going to work very well. 120 people, we are learning. There are no disadvantages of this, except when we are trying to do something hands-on, for which we might have a physical meeting, because traveling across the city for some of the people, if it is in, NIMS, for example, Bali, staying in Malakpet and coming all the way to NIMS, and maybe for many others, it might be difficult battling the traffic and all that. We might be wasting 1 or 2 hours traveling for a physical meeting. So as you said, I think this mode is really really good. And just to stay connected physically and to see each other, maybe once in a while, once in 4 months, we can have a physical as well and see how it works out.
Once in a while, when we call some guest speaker or somebody, you know, we can have a physical meeting.
Something like that. And even it would be easier for us to have speakers from across India, foreign speakers as well. We can't, I mean, obviously host them physically, paying their air tickets and all that. So I think it's a very good, I'm in mode of having the meeting. Maybe we will try for hybrid, Swarnalata. Next time we'll see how it works out. But I think we'll not abandon this meeting, COVID or no COVID. I definitely hope COVID shouldn't be there.
We can have a regular these meetings, and once a while, when we're trying to mobilize international speakers, we can have physical and or the hybrid one.
Yes.
Thanks for echoing my pain, madam, because it's very hectic to travel from LB Nagar to NIMS every time. And second thing is regarding hybrid meetings, madam, we need to have special gear, which is not so easy to acquire.
Yes.
And even though if you go hybrid, this much amount of seamless coordination can never happen. The beauty of virtual
meetings. The cost is cost is also escalate.
Cost is also escalating.
We'll just look into the logistics about it. But what we can do is stay connected virtually 3 months, and then maybe the 4th or 5th month see each other physically.
True,
something like that we can see. And at the time of a physical meeting, we can put it physical when we have some workshop, exam, maybe something like that. All of us obviously like to meet each other in person. Human contact is also important. But we can maybe have 3 months or 4 months virtually and in between physically.
Yeah. Yeah. Rather than a hybrid. Hybrid has logistic issues, Manisha. And cost-wise also it is. And then even supposing there is hybrid, I would definitely log on from home and
prefer to stay at home and then.
Yeah, I won't travel so much and then when it's going to be difficult for us.
Even in all hybrid meetings, we are seeing hardly people are there in the main halls, madam. This
even in big conferences, also same thing. Like in what happened in the ISN Chennai. I mean, though we were there physically, but we realized in the hall 2 people were there. Everybody was attending from the rooms. So what was the great fun in going there? I mean, we were happy meeting each other, having lunch and dinner together. But more than that, in the halls, absent the presence was abysmal. Nobody was there. We were all attending from the rooms.
So anyway, let's hope that this continues and at least till summer, no physical traveling, no physical meetings. I think we'll do online meetings, and it's been working very well. Except sometimes your connection, your internet connection, if it is a little bad, sometimes you go momentarily offline. But otherwise, I think it's okay. So I think I must congratulate the new team for doing an excellent job. All of you, starting from, I think, Swarna, as the secretary of this forum, you have done an excellent job, doing very well.
Yes.
Yeah. And of course, Manisha at the helm of affairs, and Manjusha, and all the others, Wali, Vikram. Shrikant, you are also the executive, isn't it?
Yes, ma'am.
Yeah, so I must congratulate all of you.
So Swarnalata, your apprehensions were ill-founded. Great job.
Yeah, but I'm wondering why Girish is not there. Has he forgotten about it?
Sir, madam, sir said, sir, relatives have come, so he'll be busy. He'll see whether he can join. So I called him before.
Okay, you called him. Okay, that's okay.
Praveen is also an important asset in our team, madam, and he's helping us a lot of work in the backdrop.
Yeah. Praveen?
Even Vikram also.
Yeah.
Yes.
So if there is nothing else, I hand over to Swarna.
And thank you, madam, for being there always. I mean, we've been seeing you from day one, and it's very inspiring, eager to learn. In fact, you're up to date with most of the things.
Most of this.
Yeah,
that makes us
really
learn.
nice. It's inspiring. People also continue to follow.
Thank you. You are the motivator, madam, for the entire team.
No.
Seniors like you, and we have juniors like all the youngsters. So
no, ma'am, you are there. Presence is so important because that makes a difference. When you can attend, join, and at this stage also learn. I mean, it's an inspiration for all of us. So really, thank you for being there.
Yeah, only thing I learned that, I mean, earlier I got thrombospondin done for one of our patients because that was available. The now I learned today that Lalpa and I don't think it should be very expensive. Otherwise, you people cannot afford it.
Yeah,
right?
It's not very expensive.
Like I think, like Srikanth said, we are moving away from just histology to probably,
we should look at the etiology, because that's again a pattern of injury, and that is not a gold standard diagnosis. It's a part of the armamentarium, one of the tools in the armamentarium. It's more exciting. Nephro has become much more exciting since the days we were.
In fact, I was just thinking when I was listening to the last talk, because we have had patients of diabetes with so much proteinuria when we think there should be some other associated glomerular disease. But when the report comes as diabetic nephropathy, I have not further evaluated. So I think that's a good learning point for me also, that we should not keep quiet when there is, especially when there is no retinopathy. If there is a retinopathy also, when there is so much proteinuria, always you have at the back of my mind whether there is any other associated glomerular disease, which I think we should go all out and make every effort to rule out any other associated glomerular disease, which can be treated. So our emphasis would be always to rule out any treatable cause, because once we diagnose diabetic nephropathy, except controlling diabetes, hypertension, your lipids, diet, there's nothing else you're going to do. ACE inhibitors, ARBs. So good learning points we got from today's meeting. So I must congratulate all the people who have one small what should I say? Not getting the right word. The Tanvi, when you know that you have just 15 or 20 minutes to present, you cannot have 54 slides, ma. It's difficult to do that. So you must know when you are discussing a case, you must know what exactly you should present and cut it down, so that, because no point running very fast. You need time. We need time to look at every slide and assimilate something from that. So it's not just running through the slides, and 54 slides to do in 20 minutes. So it's a bit difficult. So my advice to you would be to, if you have a case, just concentrate on what aspects you want to discuss, and then have a short and a nice presentation with which we will be able to imbibe, right? Okay.
Now we'll send the instructions, madam. 20 minutes, brief presentation followed by 10 minutes of discussion. And
No,
when
as an advice,
the screen will disappear after 20 minutes. That's it. So just write that. That only works. Nothing else.
Roughly, all of you should know that 1 minute, one slide. Okay. It could be a little more. Maybe if you're given 20 minutes, you can have maximum 30 slides, which some of it is only some graph or something, so that you give time for discussion.
And and better to rehearse before presenting. Timing is better.
You have to rehearse. You have to rehearse with a timer at your home, and then see that, because we used to do that. We used to always rehearse. If Manisha will remember that every time you go for some conference, we will rehearse in the department and make sure with the timer that you do not exceed the time allotted. Because it's always good
next time we'll have the timer also available.
And small crisp presentation has more impact rather than putting everything there. So art of presentation is also important, and we should not cut into other people's times. I mean, that also, they also have prepared. So so the presentation was really great. The case was great, but I think madam made a very valid point. And
because you were just running through the slides, and it becomes difficult for us to follow that speed. So at the end of it, we should not feel that we have missed out on some very important points. So you have to get the latest literature on that, some very important studies, and a very crisp presentation of your case, because you're all exam going. So that's my advice to you. It is an art. Presentation is an art, and you will get it with more and more rehearsals and more and more presentations. Because overnight, I mean, we also, first few times when you need to present, you're very nervous, but then you get over it. And you know how to adjust your time. Time management is important. So shall we call it a day?
Yes, madam.
No, I think you should. Yeah.
Madam, I think we have assigned that job to Vikram. So Vikram, can you do the, the photo?
Good evening, everyone. We come to the end of an interesting knowledge sharing session. I would like to express my gratitude to all the delegates, esteemed delegates who have attended the webinar, and their presence and contribution made this webinar successful. I extend my gratitude to the advisory board members and senior nephrologists, Dr. Anuradhaman, Madam, Dr. Krishna sir, and all the chairpersons and moderators and the presenters, especially Dr. Tanvi, Dr. Mukesh, and Dr. Anna Fatima for their excellent presentation of their work. And attendance was great, and we expect the same to be continued for the next upcoming monthly academic activities. And as pointed out, advised by Dr. Krishnan sir, we will be having, thinking of sharing these links of the recordings on the website so that they can be used for future reference. So thank you one and all for your participation.
Yeah, thank you. Thank you.
Thank
Stay
you.
tuned for the interesting.
Okay, she has gone off.
So we'll call it a day by saying good night.
Good night, everyone.
Good night.
Good night, everyone.
Night,
Have a
everyone.
wonderful
Good night.
weekend.
Good night.
Night, everyone. Thank you.